Here in our room, we have WHO Geneva from the HIV department and our HR department, and we have UNAIDS with us, Geneva with us.
Great. So without any further ado, I'll just begin the introductions and we'll start the webinar. So thank you everyone for joining. We're very excited today to be able to discuss the validation process and results. In Cuba, as many of us know, Cuba was the first country to reach validation of elimination of mother-to-child transmission of HIV and syphilis as a public health threat last month on June 30th. And so we really hope that this webinar, by bringing together colleagues from WHO Geneva, from the Pan American Health Organization, the regional office in Latin America and the Caribbean, from Cuba, including the Ministry of Health, UNAIDS, and UNICEF, that will be able to really explore and understand the process and criteria for validation of EMTCT of HIV and syphilis, and extract lessons learned about how Cuba achieved this important milestone. So thank you all for making the time to join. And without further ado, I'll turn it over to Chika Ayashi, who is the lead of strategic information at the HIV department in WHO Geneva. She also was the one of the founders of the IATT Monitoring and Evaluation Working Group, and she was the co-chair of that working group until last year. So without any further ado, I'll hand it over to Chika Ayashi, who will talk about the process for validation of EMTCT.
Thank you. To do this right. Thank you, Jessica. Can you hear me?
Yes, we can hear you. Can everyone hear? Chika, please type in and let us know if you have any problems hearing.
Great. So I will be making this presentation on behalf of the departments of HIV and Reproductive Health and Research at WHO. I will be focusing and giving a very brief overview of the global criteria and how this was developed. But I hope that, and I know most of you are here to hear from Cuba, so I'll try to make this short. And hopefully we can also hear about how this links with the global plan and what this means for high burden countries, because we've advanced our discussions around that. So I will start now. Just a quick background, and I think many of you are aware, but we just wanted to remind people that without treatment, around 1/3 of HIV positive mothers will be passing their virus on to their infants. And also without treatment, over half of HIV positive syphilis pregnancies will end in adverse outcomes. And similarly, for children, without treatment, HIV infected children, 1/3 of them will die before their first birthday, and 1/2 will die before their second birthday. And again, this is based on model data, but it's the common statistics that we quote. And just to remind ourselves that what the burden is, and that we actually have preventable interventions for these. And for syphilis, as we mentioned earlier, without treatment to the mother, over 1/2 of babies born would be born with adverse outcomes based on modeling work as well. And currently, based on latest estimates, we have an estimated 240,000 MTCT of HIV infections in 2013. I think new numbers are being released today, and it's a little bit lower, but we're really looking at over 200,000 new child HIV infections, majority of which are preventable. And for syphilis, the latest estimates are based on modeling work done in 2012, but in 2012 it was estimated that we had 360,000 adverse outcomes, birth outcomes, in infants due to untreated syphilis or syphilis that was treated late during the pregnancy. And as we know, interventions do exist for the mother-to-child transmission of HIV and syphilis. In HIV, we can reduce the transmission rate to less than 2 or less than 5%, depending on whether breastfeeding exists and the duration of breastfeeding. And for syphilis, early detection and treatment can prevent perinatal morbidity and mortality. And what we really wanted to highlight here is that both PMTCT of HIV and syphilis target pregnant target pregnant women, and they have similar control measures where we're actually trying to identify and screen pregnant women and actually treat them. And of course, there are some differences between the diseases, but we won't really discuss that right now. So, as you know, for both HIV and syphilis, or the PMTCT of HIV and syphilis, we actually have global initiatives. The global plan, as you all know, that was launched in 2011 towards the elimination of mother-child transmission of HIV, and the global elimination of congenital syphilis strategy was actually developed in 2007 and still holds today. And what's been happening with all this work around scaling up interventions for the prevention of mother-child transmission of HIV and syphilis is that a few countries have come to WHO and asked us, well, what is the criteria and how do we actually validate that we've actually achieved elimination of mother-child transmission? We are doing well, and how do we actually measure and validate that? So what we did is in 2012, we held a consultation with our technical partners, country representatives, key experts to try to develop some global guidance for EMTCT validation. And I think the meeting notes are available online, so I'll be very brief. But basically, we discussed three major topics in this consultation. One was what the standardized criteria would be for EMTCT validation for HIV and syphilis that would apply globally, regardless of epidemic types across the globe. What would the process for that be? And how do we structure the secretariat? This meeting was co-organized by WHO, UNAIDS, UNICEF, and UNFPA, and all of the discussion was also informed by country pilots, where we actually worked with our country offices and worked with 6 or 7 country counterparts to discuss what EMTCT validation would look like and what are some of the criteria that we are proposing make sense in their settings. And the basic idea was to develop a common systematic approach for the elimination of mother-child transmission of HIV and syphilis. So I keep on repeating this mother-child transmission of HIV and syphilis. I will start using EMTCT, I think, after this. So just a brief overview of terminology and definitions related to eradication, elimination, control, etc. Eradication is the permanent reduction to zero of the worldwide incidence of infection. And this is, for example, used for smallpox, as you know, and currently we talk a lot about it in terms of almost, we're at the last mile for eradicating polio across the world. So elimination is defined as a reduction to zero of the incidence of disease or infection in a defined geographical area. So we've eliminated polio from the Americas in a geographical area. And control is a reduction in the incidence, prevalence, morbidity, or mortality of an infectious disease to a locally acceptable level. And what I wanted to highlight here is WHO has a term called elimination as a public health problem, where this is showing and demonstrating that a specific disease burden has reached a very low level, either below a certain threshold or below a global target that has been set. And this is what we are using for the elimination of mother-to-child transmission of HIV and syphilis. And again, this is just terminology, but in WHO, we use the term validation to actually document the elimination as a public health problem, whereas for eradication efforts like polio, there's a much more formal certification process. Now next, so based on this 2012 consultation, we've developed these criteria for the global validation of EMTCT of HIV and syphilis. In the area of HIV, it's to reduce the HIV case rate to less than 50 new pediatric HIV infections per 100,000 live birth, and to also demonstrate an MTCT rate of less than 5% in breastfeeding populations or less than 2% in non-breastfeeding populations. The process indicators for HIV is to reach ANC coverage of 95%, the coverage of pregnant women who know their HIV status of 95%, and ARV coverage of HIV-positive pregnant women by 90%. For congenital syphilis, the impact indicator is similar to HIV. It's reducing congenital syphilis to below 50 cases per 100,000 live births. The process indicators are similar to HIV. ANC coverage of more than 95%, coverage of syphilis testing of pregnant women of more than 95%, and treatment of syphilis seropositive pregnant women by more than 95%. And in the area of HIV, what I wanted to highlight is we really tried hard and in the consultation discussed the need to be aligned to the global plan. So this MTCT rate of less than 5%, less than 2%, as you all know and should all be familiar with, is a global plan target. It's one of the key global plan targets, in addition to the new infections. And of course, you'll see the difference really between HIV and syphilis is our ARV coverage target. For the area of HIV, we've set it at 90% to be in line with the global plan, and for the area of syphilis, it's been set at 95%. So the first question people really ask is, why, and this is in the area of HIV, why we already have the MTCT rate as a target, why do we need a case rate? And basically this just illustrates that in a country where you have large numbers of births and large numbers of HIV positive pregnant women, so for example, if in a country you had 250,000 HIV positive pregnant women, even if you were able to reduce the MTCT rate to less than 2%, you would still have 5,000 new HIV positive infections. And this, of course, compounds and accumulates every year into a pediatric HIV epidemic. So in the 2012 consultation, we discussed this a lot, and what we decided is that even if we interrupted vertical transmission, child HIV infection due to MTCT will not get close to zero unless we reduce the prevalence and the number of HIV positive pregnant women, which speaks to, of course, prongs 1 and 2. And again, this is an illustration using HIV, but of course this would apply to syphilis as well. Now the next question people ask us is, so how did we decide on the case rate of 50 per 100,000 live births? So if we just focus on the highlighted yellow bars here, just in an imaginary theoretical country where we have an HIV prevalence of around 1% in pregnant women, and here you see 2 different live births. The first is 27 million. What I've done here is in 2013, I looked at estimates of live birth across all countries, and I took the highest and the lowest. I think the highest was India here, but basically 27 million live birth, and the lowest was one of the Pacific Islands with 10,000 live births. So let's say in this setting you have 1% HIV prevalence. And then you end up with 270,000 HIV exposed birth and 100 HIV exposed birth. Now applying our ideal 2% and 5% transmission rate, you end up with 5,400 new child HIV infections, 13,500 new HIV infections in the first row, and then the new child HIV infections divided by the live birth gives us the case rate, and we're looking at 20 and 50 depending on the transmission. So what I wanted to highlight here is this is what we sort of decided as the global target for validation, and we're looking at around a 1% prevalence, a country with a 1% prevalence or population with 1% prevalence, and a vertical transmission rate of 2% or 5%, and this is what it gives you. And again, the global criteria is a little bit higher because we know that there are many countries whose policy is to breastfeed for good reasons, and we want to make sure that the global criteria actually applies to all kinds of countries. However, regions are allowed to set their own targets, so you'll see later that PAHO has set their target to less than 30 because most of their countries are not breastfeeding countries. So this basically illustrates why we chose 50 per 100,000 for the HIV case rate. Now what we're missing here is a slide on syphilis, unfortunately, but we've done a similar exercise for syphilis, and it basically shows something very similar, that you need to actually, even in very low prevalence settings, you need to actually have very high case rates to be able to achieve that case rate or less than 50 per 100,000 live births. And we will be sending you updated slides after this presentation that shows the syphilis calculations. So going on to qualifying requirements for EMTCT validation. At this 2012 consultation, we discussed, well, when can a country really apply? Is it enough that they just reach this nationally? And we came up with 4 sets of qualifying requirements. The first is that a country can apply for validation once they've reached the process indicator targets for 2 years, and once they've achieved the impact indicator target for 1 or more years. So ideally, we would like to see the impact indicator demonstrated for multiple years. However, we know that in some settings, you may not actually have program data to actually demonstrate this, and maybe you do surveys or you do some sort of impact study, which can't be done perhaps annually. So in that case, we're saying that, okay, 1 year of demonstration of achievement of impact target would be okay to apply for validation. The second important qualifying requirements is a review of equity considerations. We discussed at the consultation that we don't want a country just to say, okay, we've met the criteria. We would like this criteria and this achievement of these targets we've set to be demonstrated in a low performance district or high burden area in a country, or in a specific key population or vulnerable group in a particular country that might be driving these new infections. And the third criteria we mentioned is that the country needs to have a robust national monitoring and surveillance system to actually detect new cases, and for us to be confident that they are measuring these targets well. And fourth, last but not least, we wanted to make sure that EMTCT is being met with basic human rights considerations. So we had another consultation in September 2014. It was easy to list the qualifying criteria, but people wanted a tool to actually help assess all these things we mentioned, and we set out as core principles. So in 2014, we had a consultation to discuss a data quality checklist, a lab quality checklist to verify the reliability of test results, and a human rights checklist to really support the discussion and review of key human rights considerations. And this human rights checklist also includes elements of community engagement as well as gender. And I won't go into this in too much detail because I think in Sonia's presentation we'll talk about it a little bit more. And I wanted to just mention that although we didn't discuss it in this consultation, we actually also have a costing tool available to support the costing of validation exercises and activities. And there's a program assessment tool that was used by PAHO for the Cuba validation to gather information on program and service delivery, which we are considering as a global tool. So in summary, these are the 5 tools that exist around validation. Yes?
Yeah, we just had a quick request from Cuba if you could speak a little bit more slowly to allow for translation and interpretation.
Okay.
Just, yeah. They requested that you slow down a bit.
Great.
Okay.
I'm actually approaching the end.
Okay.
So the other thing we discussed at the 2012 consultation is what the process would look like. And we came up with 3 levels, like we often do. The national level is really the team that collects and reviews and decides on all the relevant data and documentation for that country. The regional level supports the national level and again reviews the country supports, etc., and participates in these national validation assessments. They also organize for their region, dissemination of information and validation exercises across the countries in their region. The global level is where we have formed now a global validation committee, and this validation committee is the final expert committee that makes recommendations to WHO on whether a country has met the validation criteria. And again, I won't go into too much detail here because from the Cuba example, you will actually see a walkthrough of how this actually occurred. But basically, there are 3 levels. The regional and global level are supported by a secretariat, which sits at WHO, working very closely with our key partners, which is UNAIDS, UNICEF, UNFPA, and CDC. And we've also developed a summary of processes. Again, I won't go through this because we will go through this in the other presentations, but it's on page 17 of our guide, and it tells you what you do in the pre-validation phase all the way until the final validation and the maintenance of validation. And we just want to highlight again the importance of tracking and maintaining validation, that even if a country is validated for EMTCT, it's really for that specific point in time, and it would be important to maintain the same level of effort to actually sustain the validation status. So passively, what we are doing is we will continue to collect our EMTCT validation indicators through our global reporting processes, whether it's the GARPA or the post-GARPA or something else. We will continue to do this. And there's been some discussion in our global validation committee meeting to come up with more rigorous criteria to check that validation is being maintained as more countries actually start reaching validation status for EMTCT. I'm almost on my last slide. But we actually had our very first global validation expert Advisory Committee meeting in June of this year, and I just wanted to give a summary of some of the things that we've discussed and agreed on at this meeting. So the Global EMTCT Validation Advisory Committee is composed of technical experts as well as regional representation, supported by our key partners and WHO as a secretariat. We met for the first time in June. We agreed on our terms of reference. We actually reviewed the Cuba report, which we will hear about later, and assess whether the criteria, global criteria are met, and EMTCT validation was recommended to WHO. We decided to establish pre-validation benchmarks and activities, especially for high-burden countries. As you know, it's very difficult to actually reach some of the validation criteria, especially the case rate in very, very high prevalence countries. And we noted this in the 2012 consultation, but people still felt that we needed to emphasize the importance of prongs 1 and 2 to bring the prevalence down. But at this Global Validation Committee meeting in June, we also discussed the importance of actually celebrating the great progress that's being made, especially in the Africa region. That is where the highest burden is, and all the effort that's being made there is actually what's reducing our new child HIV infections globally. So we do want to actually celebrate and document that. So we will be establishing pre-validation benchmarks, and I think we'll be discussing it later in this WebEx. And again, without going into detail, the Regional Secretariat, we do work with the GVC. We've discussed our annual work plan, and we'll be further developing and updating guidance, tools, and templates. And we have a website that actually summarizes and has all the documentations available for those that are interested. So this is my last slide, and again, sorry, this is actually the old version, and the updated version has a list of acknowledgements. I wanted to acknowledge all of our key partners, UNAIDS, Carissa is the focal point, Priscilla from UNICEF, Lynn Collins from UNFPA, Chua from CDC, and actually everyone else who's been so involved with all the lab assessment tools, the human rights assessment tools, and various consultations that I can't mention here, but we will be sending you the updated slide later. So thanks, Jessica. I'm going to hand it over back to you.
Thank you, Tika, for outlining in detail and giving us an overview of the global process for global criteria for validation of EMTCT, of HIV and syphilis. And now we will go into more detail about the process at the regional level with Sonia Cafe from the regional office, the Pan American Health Organization, the regional office for Latin America and Caribbean of the WHO. She was involved in part of the regional validation committee team and is the regional advisor for adolescent health and HIV. So without further ado, I'll turn it over to Sonia Cafe, and then we will hear from the Ministry of Health in Cuba, and I will introduce them separately after she's finished. So Sonia, over to you. Sonia, are you there? You're on mute, so we might not be able to.
Yes. Hi. Can you hear me now?
Yes.
Sorry. Yes, I was muted. I hope you can hear me well. Good morning, everybody. It's wonderful to be able to participate in this session, and I hope everybody can hear me well. I'll also try to move quickly with Chica so we can give our Cuba colleagues all the time they need to share their story. What I'm going to summarize is the regional process, what led up to the Cuba validation assessment, and how that was handled from the regional perspective. I will go quickly over slides, content that Chica has already addressed. As Chica mentioned, the regional EMTCT targets are a transmission rate of 2%, and a case rate of 30 or less per 100,000, because we are dealing in our country, in our region, with mostly non-breastfeeding populations. We have the same congenital syphilis target as the global level. Now, how, in summary, how did we work up to the validation of Cuba? We started in 2012 with development together with WHO of a validation methodology. I have to mention here that before 2012, before the validation became an issue, we had already developed a methodology to do country assessments that we had been using for quite a while that was purely qualitative. And so that was for us at least the starting point to start thinking about it. What would be a reliable and a valid methodology to verify countries' achievements. And so we started thinking from that point on, and with WHO really helped push towards a more quantitative, more precise methodology that was piloted in various countries, not only in our region but in other regions of the world as well. So that continued for us during 2012 to 2014. We used the opportunity of country assessments to every time pilot the next version and the next iteration of the global validation tools in the various countries. In 2014, we established a regional validation committee, and the regional validation committee is a high-level committee that is convened by the PAHO director, and it also consists of experts, regional experts, and representatives from the UN agencies and other partner agencies such as CDC, and some of the regional, like the Canadian Public Health Agency and the Caribbean Public Health Agency. We also started the development of a roster of regional experts because we recognized that the regional committee would not be able to do all country validations in the next few years, and so we started a roster of experts in the four critical areas that Chika already mentioned, and I will go into a little more depth in a moment. So we can pull from this roster of people as needed to participate in country validation assessments. We also disseminated in a more formal manner the validation guidance in the region through a letter from the PAHO director to all the ministries of health. And we also developed standardized mechanisms for key tasks of the validation tasks, such as templates for review of country reports, etc. So those all that led into the receipt of the first validation request that came from Cuba in November 2013. And this timeline gives you a little bit of an impression how long it took the process. We don't expect that it will be this long for others, but since this was the very first country validation, and it also overlapped with continued work on development of the tools and establishment of the regional mechanisms, this took a little bit longer than we anticipate for next country assessments. In any case, it started in 2013 in November when we received the Cuba request for validation. At that point, we shared details on the process with the Cuba Ministry of Health and the Cuba team. Also on the necessity to develop a country report. And in March 2014, following some back and forth and interactions, some virtual meetings, conference calls, Cuba established their National Validation Committee that is led by the Ministry of Health. And in October 2014, Cuba submitted the country report. In the global guidance document, there's also an outline for a recommended content for a country report that is really meant to for the country to make a case that they have achieved the elimination targets. The country report was reviewed by the Regional Validation Committee and by the Secretariat, which is PAHO, the technical advisors. We shared the Secretariat with UNICEF in our region, and so we reviewed the country report and provided feedback to Cuba for improvement, for clarification. And I think that's also important that we learned that this is really an iterative process. Once a country has developed their report, that there's a process of back and forth until everybody, all the partners are satisfied with the content of that report. In December 2014, we conducted a pre-validation visit to Cuba, and it was a joint delegation, 4 people, 2 from the Regional Validation Committee and 2 from the Secretariat. And the main purpose of that pre-validation visit was to do a more in-depth review of the pending questions and discussion of the pending questions in the validation report, to orient the Cuba team on the validation process, and to start preparing for the actual validation mission. At that time, it was agreed that the validation mission would take place in March of the following year in order to facilitate all the preparations needed. And so that is also what happened, and I think this looks very small, but I hope you can read it. The 4 tools that were used were the data verification and impact assessment, the laboratory assessment tool, the tool for human rights, gender equality, and community engagement, and a program and services assessment. So how did we organize the field work? The main job, I think, was to select the regions and the sites to be visited. Trying to comply with the global requirement of equity, we tried to define together with the Cuba team what would be considered the lowest performing subnational units. And we considered quite a few criteria. We considered the coverage indicators or process indicators. We considered the impact indicators, in which regions, which municipalities is transmission happening. And so we went through this, looking at all the available data from Cuba. We went through all these criteria to try and identify what would be in Cuba we could define as lowest performing subnational units. I have to say that it wasn't very easy, because Cuba, and I'm sure in their presentation they will highlight it, Cuba had very, very high coverage of essential services, and the numbers of HIV transmissions and congenital syphilis were very low. And so we finally decided to focus on other factors in terms of 3 main criteria. Where were the last in transmissions? Where did they take place? And we also looked at a little bit of geographical variance, urban, rural settings, and based on that, we finally we selected sites, and with regions, and within these regions, municipalities were selected, and within these municipalities, then the sites that would be visited, which were maternity houses, hospitals, polyclinics, family care centers, and of course in Havana itself we also visited all the relevant national programs to interview. And a quick overview of what happened under each of the tools. The validation questions for programs was: is there an adequate structure for programs and services? Are the services universally available and accessible? And is there any guarantee for sustainability? And what the verification process included: interviews and also review of national plans and strategies and other relevant documents. For human rights, gender equality, community engagement, we reviewed the issues that were identified on global level as critical: criminalization of vertical transmission, mandatory or coerced testing, informed consent, etc. And the methodology that was that took place there was desk review of human rights and gender equality instruments that the country has signed, reports, shadow reports, all the available reports related to these 10 topics, and also stakeholder interviews, both individual and group, of a wide range of stakeholders. We interviewed over 200 people altogether in the 4 areas. For laboratory assessment, the question was, is there an adequate lab network to provide appropriate services, and are the results generated by the lab network adequately reliable, sensitive, specific, and quality assured? And so, oops, there's no slide on how, but basically the lab tool also facilitated in-depth review of not only the processes, but the instruments of the labs on the different levels, the national labs, the subnational labs, and the local laboratories. And also there was also a module to assess point of care testing, which was not much taking place in Cuba with rapid testing. And so the 4th component was data verification and impact assessment, and there the validation questions were, is the data generated by the country reliable to assess achievement? And then of course the critical question, has the country achieved the targets? And the verification also included interviews with stakeholders, review of databases and paper-based information systems, review of client records, spot checking, cross-checking, review of the cases of vertical transmission across the different level of care. So tracking of these cases across the different levels of care to verify the data, and also review of stillbirth records that's mostly related, of course, to congenital syphilis, to ensure that stillbirths are included in the congenital syphilis data. And so based on this assessment that took place over the course of 1 week with quite a large team of 20 people that included some observers from global level and from other WHO regions, the validation team concluded that Cuba had complied with the global and regional criteria and recommended Cuba to WHO for validation. And as Chica explained, the next step was that on global level, the global committee reviewed the report from the regional committee and the Cuba report, and had quite some pertinent questions and discussions, based upon which they decided to endorse this recommendation. Thank you so much, and that ends my presentation.
Thank you, Sonia, for giving us a review of the step-by-step process followed at the regional level to validate Cuba and the elimination of mother-child transmission of HIV and syphilis. And now for the moment we're all been waiting for, the Ministry of Health, 2 representatives from the Ministry of Health of Cuba will be presenting to share with us lessons learned from their experience and really explain how Cuba achieved this important goal. We have 2 presenters who will be presenting jointly. And before I introduce them, I just ask everyone to be patient, as after each slide, there will be a translation from Spanish to English. So our first presenter is Dr. Jose Juanes Fiol, who is responsible for monitoring and evaluation and focuses on HIV/AIDS. And our second presenter is Dr. Katia Ale Rodriguez, who is responsible for sexually transmitted infections and monitoring and evaluation of STI programs as well. So as I load up the presentation, I'll turn it over to the team in Cuba, who is also joined by Alina Perez of the WHO in Cuba. Hello? Can you hear me? Can you hear? Hi, can everyone hear?
Good morning, it's Dr. Fiol.
Okay.
We can hear you.
Okay,
Good morning,
great.
everybody.
Good morning.
We refer to talk Spanish.
Yes, that's fine.
Bueno, ante todo agradecemos la oportunidad que nos brindan de exponerles algunos aspectos del trabajo de Cuba que contribuyeron al que el país cumpliera con los requisitos de la validación de la eliminación de la transmisión materna infantil de VIH y la sífilis.
Good morning. Well, first of all, we would like to thank you for the opportunity that is provided to us to show you some of the aspects of the work of Cuba, which helped the country meet the requirements for the validation of the elimination of mother-to-child transmission of HIV and syphilis. Could you please show the slides?
Yes, we're showing the slides. Do you see on top you can take over as presenter? If you say take
Jessica,
over,
could you repeat?
if on top you should say there should be an icon that says take over as presenter, and then you can change the slides as you go, which will be easier for translation.
Bueno, en los primeros años de la década del 60, la atención a las infecciones de transmisión sexual era realizada principalmente por dermatólogos en dispensarios para el tratamiento de enfermedades venéreas y lepra. La sífilis congénita constituía entonces un importante problema de salud y anualmente se reportaba un gran número de casos.
In the early years of the 1960s, care for sexually transmitted infections was provided mainly by dermatologists at doctor offices that provided treatment for venereal diseases and leprosy. Syphilis, congenital syphilis, posed then a significant health problem, and annual reports indicated that there was a large number of cases.
En 1962 se puso en vigor el primer programa para el control de la sífilis, conducido por el Departamento de Dermatología Sanitaria. Se estableció la atención gratuita en consultas dermatológicas de hospitales y mejoró la notificación de casos. Sin embargo, era insuficiente la cobertura de atención e inexistentes las acciones de control epidemiológico.
In 1962, Cuba started to implement the first syphilis control program, which was led by the Department of Health Dermatologists. We established in Cuba free care at dermatological consultation offices at hospitals, and we improved the notification of cases. However, the coverage of care was insufficient, and the actions for epidemiological control were inexistent.
En 1972 se actualizó este programa con un enfoque diferente. Mayor prioridad a las acciones de búsqueda de casos, la investigación y el análisis epidemiológico. Acciones que se realizaban en policlínicos comunitarios como expresión de su integración al modelo de atención en la comunidad.
In 1972, we updated this program and applied a different approach. We turned it into a major priority for the actions to identify cases, conduct research and epidemiological analysis, as well as implement actions at community-based polyclinics as an expression of its integration to the community-based care model.
En esta misma época se implementa el programa de atención materno-infantil, que ha tenido un continuo perfeccionamiento y constituye la plataforma para la prevención de la sífilis materna y congénita. La atención prenatal del parto y puerperio es llevada a cabo por personal de salud calificado y el 99.9% de los nacimientos ocurren en instituciones de salud. Cada gestante recibe un mínimo de 10 controles prenatales por el médico de familia e interconsultas con especialistas de ginecología y obstetricia. Durante la atención se da seguimiento a su estado de salud, lo que incluye la realización de serologías de sífilis y VIH a ellas y sus parejas sexuales.
At the time, we also implemented the Mother and Child Healthcare Program, which has been continuously improved over the years and provides a platform for the prevention of maternal syphilis, maternal and congenital syphilis. Antenatal care, delivery care, and puerperion are carried out by highly skilled health staff, and 99.9% of births take place at healthcare institutions. Every pregnant woman is given at least 10 antenatal controls by the family doctor and interconsultations with specialists of gynecology and obstetrics. During the care, follow-up is provided to the health condition, which includes the development of serological tests for syphilis and HIV to these pregnant women as well as their sexual partners.
Actualmente se realizan alrededor de 1.5 millones de pruebas serológicas para sífilis, de ellas más de 300.000 gestantes, con una cobertura del 99%. Desde 1980, la tasa anual de sífilis congénita se ha mantenido por debajo del criterio de eliminación establecido en la estrategia regional aprobada en el 2010. En los últimos 4 años ha oscilado entre 0 y 0.04 por 1.000 nacidos vivos.
Annually, we conduct around 1.5 million serological tests for syphilis, including over 300,000 to pregnant women, with a 99% coverage. Since 1980, the annual rate for congenital syphilis has been kept below the criterion of elimination established under the regional strategy that was adopted in 2012. In the last 4 years, it has ranged from 0 to 0.04 every 1,000 live births.
Desde el inicio de la década de los 80 se constituyó por decisión del gobierno el Grupo Operativo para el Enfrentamiento y Lucha contra el SIDA, que elabora, desarrolla y ejecuta políticas en función de dar respuesta a la epidemia de VIH. Lo integran sectores sociales, organizaciones y asociaciones de la sociedad civil, lo que asegura el enfoque intersectorial de la respuesta. Funciona a nivel nacional, provincial y municipal y es asesorado por la Comisión Técnica de VIH-Sida.
Since the early 1980s, we established, upon a decision by the government, the operational group to cope with and fight against AIDS. This group puts together, develops, and implements policies to give an answer or response to the epidemic of HIV. The group is made up of social sector representatives as well as those of organizations and civil society associations. This ensures the application of a cross-sectoral approach to the response. The group operates at the national level, at the provincial and municipal levels, and is advised by the Technical Commission on HIV/AIDS.
El programa de prevención y control del VIH-Sida fue elaborado en 1986, basado en enfoques de salud pública conocidos y previamente aplicados en el país para la prevención y control de otras enfermedades. En particular, fueron utilizadas las experiencias en el control de infecciones de transmisión sexual y se implementaron acciones dirigidas al diagnóstico precoz, la investigación epidemiológica, la notificación de parejas, la educación de la población y la organización de servicios de prevención, atención y tratamiento a los afectados.
The National HIV and AIDS Prevention and Control Program was developed in 1986 on the basis of public health approaches that were well known and had previously been implemented in the country for the prevention and control of other diseases. In particular, we built upon the experiences that we gained in the control of sexually transmitted infections, and we implemented actions aimed at early diagnosis, epidemiological research, notification of sexual partners, education of the population, and organization of services for prevention, care, and treatment of those affected.
Para dar sostenibilidad al programa, la red de centros científicos del país garantizó la investigación, el desarrollo de recursos humanos y la introducción de tecnología que han asegurado el acceso de la población a la prevención, el diagnóstico, la atención y el tratamiento.
To sustain the program, the network of scientific centers in the country guaranteed research, the development of human resources, and the introduction of technology that have made it sure to provide access to the population to prevention, diagnosis, care, and treatment activities.
El componente educativo ha desarrollado entre sus estrategias básicas la información, educación y comunicación, la consejería, el mercadeo de condones y un enfoque intersectorial y comunitario. Las acciones desarrolladas y la creciente participación de la población, las personas con VIH y demás grupos clave han tenido un impacto positivo en indicadores de cambio de comportamiento de la población cubana.
The educational component has included several basic strategies: information, education, communication, counseling services, condom marketing, and the implementation of a cross-sectoral and community-based approach. The actions developed and the growing participation of the population, the people living with HIV, and other key groups have had a positive impact on attitudinal change indicators in the Cuban population.
Hasta diciembre del 2014 se habían diagnosticado 21.922 personas con VIH. Habían fallecido 3.652 y vivían con VIH o SIDA 18.270 personas. La prevalencia en la población de 15 a 49 años es de 0.25%.
By December 2014, we had diagnosed 21,922 people with HIV. We had had 3,652 deaths, and living with HIV or AIDS, there were 18,270 people. The prevalence in the population age 15 to 49 stands at 0.25%.
El sexo masculino es el más afectado y representa más de las 3/4 partes de la epidemia. Los hombres que tienen sexo con hombres constituyen el 72.8% de todos los casos diagnosticados y el 89% entre los del sexo masculino.
Men are the most affected, and they account for over 3/4 of the epidemic in Cuba. Men having sex with men make up 72.8% of all cases that have been diagnosed, and 89% of those among men.
Para la prevención de la transmisión materno-infantil del VIH, el programa aplicó y adaptó en cada momento y al contexto nacional las acciones científicamente recomendadas, la realización de la prueba de VIH en la primera consulta prenatal, el parto por cesárea y la suspensión de la lactancia materna eran las únicas medidas preventivas que se aplicaban a finales de los 80. La tasa de transmisión superaba entonces el 40%. La realización trimestral de serología de VIH durante el embarazo, el estudio de las parejas sexuales, la terapia antirretroviral combinada, la medición de carga viral para monitorear su efectividad, el parto por cesárea, el tratamiento preventivo a recién nacidos y su seguimiento clínico y laboratorio componen la estrategia preventiva que aplicamos. La tasa de transmisión materno-infantil del VIH ha sido igual o menor al 2% en los últimos 3 años.
For the prevention of mother-to-child transmission of HIV, the program implemented and adapted to the national context at every stage. The actions that have been scientifically recommended. The realization or conduct of HIV tests in the first antenatal consultation, delivery using cesarean sections, and the suspension of breastfeeding were the only preventive measures that had been applied until the 1980s. The transmission rate exceeded then 40%. quarterly serological tests for HIV during pregnancy, the study of their sexual partners, combined antiretroviral therapy, the measurement of the viral load to monitor its effectiveness, delivery using cesarean, and the preventive treatment to newborns and clinical and laboratory follow-up are all components of the preventive strategy that we are implementing. The mother-to-child transmission rate of HIV has been equal to or lower than 2% in the last 3 years.
La atención y tratamiento de las personas viviendo con VIH están integrados a la red de servicios de salud. Se desarrolla a partir del consultorio del médico y enfermera de la familia. Participan además especialistas del policlínico que han sido entrenados en VIH-Sida y se utilizan los diferentes servicios existentes según las necesidades individuales, lo que incluye la derivación a los niveles secundario y terciario de atención de ser necesario.
Care and treatment for people living with HIV have been integrated into the health service network. It is developed on the basis of or based on the family doctors and the nurse office. They involving also specialists at the polyclinic who have been specially trained on HIV/AIDS. And they use various services available depending on individual needs, including referral to the secondary and tertiary levels of care if necessary.
En colaboración con el Fondo Mundial de Lucha contra el SIDA, la tuberculosis y la malaria, se han creado capacidades para asegurar el acceso a los estudios especiales de seguimiento y hoy contamos con 9 laboratorios de citometría del flujo y 5 de carga viral.
In collaboration with the Global Fund to Fight AIDS, Tuberculosis and Malaria, we have built up capacities to ensure access to special studies to follow up. And today we have 9 laboratories for flow cytometry and 5 laboratories for viral load.
Cuba ha realizado grandes esfuerzos para garantizar el acceso a tratamiento antirretroviral gratuito a quienes lo requieren. La investigación, desarrollo y producción local de estos medicamentos, el acceso a la atención que facilita el Sistema Nacional de Salud y la cooperación técnica recibida nos ha posibilitado alcanzar este resultado. Hoy reciben tratamiento 13.075 cubanas y cubanos.
Cuba has made huge efforts to guarantee access to free antiretroviral treatment to those in need. Research, development, and the local production of medicines, as well as access to care that are facilitated by the national healthcare system and the technical cooperation that we have received. All this has made it possible for us to obtain these results. Today, there are 13,075 Cuban men and women under treatment.
En respuesta al compromiso asumido en el 50º Consejo Directivo de la Organización Panamericana de Salud en el año 2010, Cuba comenzó el proceso de validación de la eliminación de la transmisión materno-infantil de VIH y la sífilis en noviembre de 2013, expresándola en solicitud formal a la OPS. A partir de la solicitud se produjo un gran movimiento del equipo nacional, talleres de la herramienta de validación, visitas de monitoreo, formación de equipos, aplicación del instrumento previamente de forma local. Esto trajo aparejado un aprendizaje colectivo. Una vez enviado el informe del país, se inició un proceso de intercambio entre el equipo nacional y el Comité Regional de Validación. Se organizó la previsita de validación los días 4 y 5 de diciembre de 2014. Durante esta, expertos regionales evaluaron la fiabilidad del informe, intercambiaron informaciones y criterios con el equipo local y fue organizada la visita de validación del 23 al 27 de marzo del 2015.
In response to the commitment that had been assumed at the 15th Directed Steering Council of the Pan American Health Organization in 2010, Cuba embarked on a process of validation of the elimination of mother-to-child transmission of HIV and congenital syphilis in November 2013. expressing this in a formal request to the Pan American Health Organization. These are part of the lessons learned. Building upon the request made, we were able to mobilize the national team, hold workshops, develop tools, organize monitoring visits, trained teams, and implement an instrument that had been previously locally tested. This has brought about a number of lessons learned. Once the country report was finalized, we started a process of exchange between the national team and the regional validation committee. We organized the pre-visit for validation on December the 4th and 5th, 2014. During this visit, regional experts assessed the reliability of the report, exchanged information and criteria with the local team, and we agreed to have the visit for validation organized on 23-27 March 2015.
El Comité Regional de Validación estuvo integrado por expertos en diferentes áreas y observadores pertenecientes a la OMS y OPS, ONU-SIDA, UNICEF, Comunidad Internacional de Mujeres Viviendo con VIH, CDC, entre otros. Fueron visitados en diferentes provincias consultorios de médicos y enfermeras de la familia, policlínicos, hospitales y hogares maternos, unidades de procesamiento de información, laboratorios y entrevistados directivos de programas, así como población beneficiaria de los servicios.
The Regional Validation Committee was made up of experts from different areas as well as observers under the umbrella of the World Organization and the Pan American Health Organization, UNAIDS, UNICEF, the International Community of Women Living with HIV, the Disease Control Center of the United States, among others. The number of institution visitors in different provinces included doctors and family doctors and nurse offices, polyclinics, hospitals, and maternity homes, as well as information processing units, laboratories, and we interviewed executives or managers of programs, as well as the population that was benefiting from these services.
El Comité Regional concluyó la visita expresando sus valoraciones y anunciando los próximos pasos, proceso que concluyó con el reconocimiento de haber alcanzado la validación de la eliminación de estas enfermedades.
The Regional Committee concluded its visit expressing its views and announcing the steps to be taken as part of a process that concluded with the recognition of having for Cuba to have reached the validation of elimination of these diseases.
Thank you very much.
Thank you. Muchísimas gracias, Dr. Field. Thank you so much. We're very delighted and honored that you were able to join us and give the presentation on Cuba's story related to validation. And I'm sure that we will be fielding questions from our participants later on at the end of the webinar. And without further ado, I'll turn it over. We have 3 very quick and brief presentations. The next one is from Deborah von Zinkernagel, who is the Director of the Office of the Global Fund and Global Plan Affairs for UNAIDS, and she will be discussing the implications of validation for the global plan and for other countries with different epidemiological contexts. And I think it's very exciting. UNAIDS announced this morning that globally there was a decline of new HIV infections by 35%, as well as a decline in AIDS-related deaths by 41%. So with this backdrop, I think the news on the validation in Cuba is that much more important and exciting. So we'll be discussing in this presentation and further on in our Q&A session of how the lessons in Cuba can be applied in different regions and contexts. So over to you, Deborah.
Okay. Well, thank you, Jessica. Thanks very much for the chance to join this webinar today. It's an honor to follow the presentation by Cuba and to learn and to hear more about what's been achieved there in addressing the HIV epidemic. It truly is impressive and admirable. And appreciate also IATT for putting this webinar together. I think it's a real service to get the information out as widely as possible, and very appreciative to you and colleagues from PAHO for doing this. I'm glad that Miriam Chipimo, who's our Strategic Intervention Advisor from the Caribbean Regional Office, is able to join us today as well online and can handle maybe some of the questions that I'm not able to. But in the region, she's also available and helping other countries who are interested in sort of following what Cuba has also sort of led the way on. So I'll keep these remarks somewhat brief around the relationship of the global plan, work to sort of the validation process that we're talking on today. A quick overview, I think, of the global plan and what our key measures and targets have been. First of all, I would say it is a global plan. So I think we're looking at a worldwide charge of really eliminating new pediatric infections. And the plan itself has focused heavily on 22 countries, which account for 90% of the new HIV infections in children. But we do look at it as a global responsibility. There are two sets of the key measures that we're aiming for. One is a 90% reduction in new infections in children. The baseline for that is the 2009 data. The plan itself was developed in 2010 and launched in 2011, but that was the best data at that point in time to utilize, and that's what we have pegged ourselves to. We are looking, as Chica has also mentioned, looking at the differential rates of transmission to be achieved in non-breastfeeding and breastfeeding countries. And then we hold ourselves also to look at the age-related maternal deaths as an important piece of keeping mothers alive as they care for their own health and also their children. We've looked also at, I think, more broadly, I've mentioned we focused in heavily on the highest burden countries. The data that we'll be collecting on this part of the plan will be final in the summer of 2016 when we have the end of the 2015 data in, but we hope to be making significant progress by that point. Which way go down? Down. Okay. Already, I think we have seen there's an opportunity that in the world at this point that over 85 countries already have less than 50 new infections in children as of the most recently available data. Some of those are small nations. However, I would say that with 50 new infections, it is within reach to dream and hope that we can take that number all much farther down. There are four large main prongs. I think you may all be familiar with these, but I'll run through them quickly because they have some bearing, I think, to the measures that are being evaluated in the validation process. We look at reduction, the overall targets which I've mentioned at the top are reduction in new infections in children and also the deaths among women. But that's inclusive, I think, of prong one, which looks at primary prevention in women of childbearing age as a critical point. Prong two is looking at the availability of family planning services for those who wish to make decisions on their own reproductive health. Prong three is the one that most are familiar with, and that is looking at the interventions during the antenatal and breastfeeding period to make sure that mothers receive HIV test, that they're offered prophylactic ARVs for their own self, and then appropriate care and treatment for their infant when born. In some countries, that the cesarean section is offered as a part of that, which has been referenced by our colleagues in Cuba as an additional measure, which can sometimes afford a reduced risk during the perinatal period. And then prong four is important as well, which is continuing treatment, I think, for women who need HIV, need antiretrovirals for their own health, and also for those children who are positive to make sure that we don't forget and look for early diagnosis and prevent the complications of early HIV infection on growth and development. Oops, backwards. I'm going to go backwards. Okay. This is a quick graphic that shows you sort of where we started and where we have come to now. as with the interventions developed as effective for preventing vertical transmission, we've seen, looking back into 2005, where the data picks up on this, there's obviously earlier data. There was already a trending down as guidelines were being developed. And then looking at where we started to look at a baseline data of 2009 through the data for the end of 2013, we had seen an acceleration in the rate of decline, which really did show as countries were picking up and developing acceleration plans, putting a lot of emphasis in this. We've been pleased at exactly at how much has been achieved. The target has been under 40,000 new infections, so a ways to go. The acceleration curve is one that we are definitely hoping will continue, and many countries are doing an extraordinary job of going towards that target. The global plan, I think, we see it as very much complementary and supportive of the WHO validation processes. I think we've looked at it as an accelerated action to achieve the end to vertical transmission, while the validation is actually measuring that achievement towards EMTCT. So I think we work hand in hand on many of our principles and look at these as very complementary to each other. This is a bit of a modeling slide, and I put it forward as a hypothetical in part to sort of look at what happens over time, often in epidemics, where on the left you might see a hyper-epidemic state when there's large numbers of cases, large numbers of new infections, and much lower number there on the bottom of sort of the testing and identifying women who are positive and in need, moving more towards a control phase where you start to see the gap narrowing between the new infections and the case detection rate. Many countries in the global plan are in that space now, moving on to what could be maybe looked at as a pre-elimination phase, where you actually begin to have a merging of those numbers, where you're identifying most, if nearly all perhaps, of the new infections and being able to intervene onto an elimination phase, and then post-elimination phase, which would be our ideal for all of us of really eradication. But this is more to say this is a continuum, and I think countries are at different places along this line, and we're in discussions with WHO colleagues. How do we look at some of the higher burden countries which may still have significant numbers of infections, but actually are making tremendous progress on the rates of transmission, South Africa being one where it's around 2%, really extraordinary programmatic progress, and wanting to take note of that as we go forward. One of the, I think, really exciting pieces that has come that is new in the validation process is the consideration of a human rights, gender equality, and community engagement component, which is, I believe, the first time that we're seeing this in a WHO validation process. This hasn't been something in the typical diseases of smallpox, polio. So I think it's really, we're very appreciative of the thought and work that's been put into this as we look at reaching the targets of validation, but in a way where the rights of women, this not through coercive practices, whether it's forced sterilizations, abortions, or etc. So to sort of develop this criteria, we had multiple meetings and consultations with groups of women living with HIV, with community folks, with human rights experts to say what are the things that would be most important to us from a public health perspective to be inquiring as we look at reaching this validation target. I think the top of the list, obviously, when you criminalize vertical transmission, you have all the wrong messages of having people not wanting to come forward for care. I think issues around mandatory and coerced testing are ones that need to be looked at carefully. This is not this is a list I think that we need to look at often in a case-by-case environment, in that informed consent can mean very different things in different countries. But I think the principle of not a forced action or uninformed action is one that holds true. So each of these are things that may be brought forward as considerations or for areas of further progress in countries which may be making extraordinary progress simply on their case rates. And just to keep in mind, this is where we're headed, and our goal, I think we need to put syphilis into this as well, but definitely I think throughout the global plan, the goal really is to, again, get these numbers down to zero. There's no reason at this point in time when a child needs to be born with HIV, when we have the knowledge and the tools at hand to end that. And then obviously the large goal of getting this epidemic fully under control by 2030. So with that, thank you very much, and we look forward to the discussion.
Thank you, Deborah, very much for your insightful presentation and for giving us the global outlook on where we are in terms of progress towards elimination of mother-child transmission of HIV and syphilis. So I think what we'll do now is field some questions, particularly around Cuba's experience, and then we will end with next steps on validation, as I know we're all eager to hear from the Ministry of Health in Cuba and the team in Cuba about their experience. So and I'm here with Priscilla Adele from UNICEF, who will also facilitate the Q&A session with us. So the first question was regarding the mass media campaign and what type of strategies did the Ministry of Health in Cuba use in terms of a mass media campaign, radio, TV, and what type of messaging was included. So over to the team in Cuba. Are you there? Dr. Fiol?
Yes, good morning.
Yes.
Le habla la doctora Katia.
Yes, my name is Dr. Katia.
Y bueno, a ver, desde que comenzó el programa de VIH-Sida en el 86 se incorporaron.
Since the HIV program started in 1986, we decided to implement
las campañas de comunicación en todos los medios de difusión masiva.
Education campaigns using the mass media.
Que incorporan la radio, la televisión, la prensa.
Including radio, television, and the printed press.
A partir de los últimos años, la última década, nosotros hemos enfatizado mucho el trabajo de los medios en los grupos vulnerables.
In the last 10 years, we have been making a lot of emphasis on the media actually focusing on the most vulnerable groups.
Y aunque consideramos que nos falta todavía mucho por hacer, hemos logrado impacto en estos grupos vulnerables a la epidemia.
And although we have still a long way to go, we believe that we have made headway in dealing with these highly vulnerable groups to the epidemic.
Para nosotros, la comunicación en los medios es un elemento importante para la estrategia de comunicación, de información y de acción para el programa en sentido general.
For us, the media played a key role in the different campaigns that we promote, including education, awareness raising, and decision making. Yes, that is my answer. I do not know if you have any question.
Okay, thank you. Thanks everybody for the excellent presentations. We have more questions for Cuba. One question is, what kind of incentives have been used by Cuba to maintain volunteers?
Bueno, en Cuba se estimula mucho el trabajo de los voluntarios.
In Cuba, we try to encourage as much as possible the work of volunteers.
De hecho, son personas que por sí quieren trabajar con nosotros, pero no son pagadas.
These people actually are interested in working with us, but they are not getting paid for their work.
Son personas que se sensibilizan y que nos ayudan a trabajar en el componente educativo de la epidemia pero que no son para nada pagadas. Los estímulos son morales, de reconocimiento.
We basically use moral incentives, that is, we provide them with certificates, recognition in writing, but we do not pay them for this work.
Y hasta ahora nos ha dado resultados.
And so far, the results have been quite encouraging. So this is it. Excuse me, can you hear me?
¿Se cayó la comunicación?
Hello, good morning, can you hear me?
Yes, we can hear you. Can you hear us?
The doctor has concluded her answer. Do you have any doubt or question?
Yes, we had a follow-on question. Can you hear me?
Yes, we can.
Yes, I was asking, of the volunteers, are they people living with HIV or anyone in the community, irrespective of their HIV status?
Bueno, los voluntarios en Cuba son un grupo mixto. Hay personas con VIH y hay personas que no están infectadas con VIH.
Volunteers in Cuba are made up of people who are infected with HIV and others who are not infected with the disease.
En muchos casos incluyen familiares de personas con VIH y personas que trabajan la epidemia sin VIH.
Many of them are relatives, family members of those who are affected by the disease, and there are many other people who are not infected.
Thank you.
There are two follow-up questions. One is regarding any issues or challenges found with regards to stigma and discrimination. And the second is, what was the strategy used by Cuba to increase partner testing?
A ver, desde el comienzo del programa de ITS,
Since the beginnings of the sexually transmitted infections program,
nosotros tuvimos incluido como estrategia epidemiológica clave el estudio de las parejas.
we included as a key epidemiological component the study over sexual partners.
Pero todo se basó en consentimiento informado,
Everything based on informed consent,
en negociación de querer o no hacerse una prueba,
and asking whether or not they would like to have the tests performed,
y en el convencimiento hacia la persona de los riesgos que estaba adquiriendo él y la pareja que no estaba infectada.
trying to convince HIV positive people of the risk that they were taking as well as their sexual partners.
Esas fueron las principales acciones realizadas para el estudio de las parejas sexuales.
This was the main actions developed to study
Las parejas.
the sexual partners.
Con relación al estigma y la discriminación,
In connection with stigma and discrimination,
hemos trabajado mucho desde adentro del programa con las personas con VIH,
we have been working very hard, especially with people under the program with people with HIV positive
que se han empoderado,
who have been empowered.
y hemos trabajado mucho con los equipos de salud a nivel de la base.
And we have also been working hard with the local healthcare teams at the grassroots level.
Esas son las principales acciones que hemos hecho.
These are the main actions that we have implemented to cope with these challenges.
Aún individualmente persisten algunas situaciones específicas
However, there are some specific individual situations in terms of stigma and discrimination
que son trabajadas individualmente en los territorios donde se da la situación.
They are usually dealt with in the territories, in the districts where these situations occur.
Y hasta ahí hemos llegado. Nos falta mucho por hacer todavía, consideramos, pero hemos avanzado.
We know that we still have a long way to go, but we also know that we have made progress. So this is her answer. Any question?
This one is to Chika, given that a number of countries will be going on to try to implement specific processes for validation, is there a repository for tools that are currently being used, particularly those that were used in Cuba, that will be accessible to those who want to adapt them?
We can discuss with PAHO. I'm speaking for WHO and PAHO, but we can discuss with PAHO on making them available. Of course, they would be in Spanish, the tools that we're using in Cuba, and they're very much aligned to the draft global tools, although there were a few questions added. But I think we can actually make a repository available of the draft tools. Also, for your information, the Global Validation Advisory Committee met in June. And we were meant to discuss the tools in detail at the meeting. But
Hello? Can you hear us? Hello? Okay. Hello? I think WHO lost sound. Can you hear me? Okay. So unfortunately we lost WHO Geneva, but basically they were saying that a repository of tools can be made in the future. So we will look out for that and share that with you once it's available. A couple more questions for the Cuba team. The first is regarding how Cuba plans to maintain the elimination status. So what mechanisms are in place to ensure that elimination of mother-child transmission of HIV and syphilis is maintained? And the other is regarding task shifting. And this question is from Namibia, as one of the bottlenecks is task shifting to allow nurses to initiate and manage ART as opposed to doctors. So what was the Cuban approach in this regard? And lastly, the last question, if you can take them all at once, is what was the endpoint for determining the EMTCT rate, or mother-child transmission rate, excuse me? Was it 6 to 8 weeks, or was it 18 months, or the end of breastfeeding? Did you get that? Is the team in Cuba still with us?
Yes, we are.
Okay.
Bueno, a ver, para Cuba es un gran reto en estos momentos. Todo lo que ha pasado es una satisfacción para el programa. Y la validación.
In fact, this elimination is a source of satisfaction for the program in Cuba.
Y la validación nos dejó un saldo positivo.
And the validation had actually a very positive impact on us.
En cuanto a integración de los servicios, a mostrar la integración de los servicios.
Because we realized that we needed to show how well integrated these different services are.
Que es lo que normalmente a expresar o a mostrar lo que normalmente nosotros hacemos con el trabajo diario.
It's basically to show what we usually do on a daily basis.
Y fue un proceso de aprendizaje, de incorporar a nuestro trabajo las herramientas.
So it was a learning experience for us after the validation, that is, starting to incorporate the tools
y los mecanismos y formas de verificación de datos para la triangulación dentro de nuestro programa de monitoreo y evaluación.
and data verification mechanisms for the triangulation within our ministry and within our own structures.
Hoy estamos en el momento de empoderar a los territorios que no participaron en el ejercicio de la validación.
We are now in a process of empowering the territories, the districts that were not involved in the validation exercise.
para extender las experiencias e incorporar todos los elementos necesarios para llevar el monitoreo adecuado de la validación.
So that the experience can be replicated there and we can actually take there all the necessary monitoring mechanisms.
Mantenemos el monitoreo sostenido y sistemático de todas gestantes,
We systematically monitor and follow up all our pregnant women,
tanto con VIH que con sífilis,
suffering from both the HIV and or syphilis.
y hemos enfocado para mantener esto además el estudio de los niños como elemento fundamental en el monitoreo y la evaluación constante.
And for constant monitoring and evaluation exercises, we have already included the study over children.
Tenemos que hacer mucho en la parte educativa con las personas todavía.
We still have to work a lot on the educational component that is working with people.
Y estamos trabajando en un plan de acción
And we are working on an action plan
en función de las recomendaciones que nos dejó el equipo de validación regional.
following the recommendations of the regional validation team,
Donde consideramos que son elementos fundamentales para mantener la organización de nuestro sistema y los resultados que hoy tenemos.
we believe that this is of the essence to be able to keep the results that we have achieved and move further.
En relación a la imposición de tratamiento antirretroviral por parte de las enfermeras,
In connection with task shifting, that is, for example, leaving the responsibility of administering antiretroviral treatment, this responsibility in the hands of nurses,
realmente en el plan estratégico está establecido que es el médico que indica la terapia y la enfermera se utiliza principalmente para controlar la adherencia a dicho tratamiento.
it is the family doctor the one who actually has to assume this responsibility. And under the strategic program in Cuba, we just leave the task for the nurse to it's to actually control or follow up adherence to treatment.
Realmente la epidemia en el país no es tan grande como para tener que usar enfermeras en esta tarea.
In fact, the epidemic in Cuba is not that huge as that we would need to actually involve nurses in this in the doctor's task.
Y la cobertura de médicos de familia y otros especialistas es alta. No tenemos que llegar a ese estado todavía.
There is a high coverage of doctors in Cuba, so we do not have to rely on nurses yet. So that is the doctor's answer. Is there any other question?
Yes, there is one more. The question is, how do you increase retention, ensuring that mothers and children are retained in care without being lost? How do you maintain them on treatment so that you do not lose them?
Bueno, las madres y los niños se mantienen en el programa a través de la misma línea de personas con VIH que está dentro del componente educativo del programa.
Mother and child care, the pregnant HIV positive mothers and children are followed up under the national program.
Muchas se incorporan al trabajo educativo incluso con nosotros.
Many of them actually join the educational work that we usually do.
Y a través del médico y la enfermera de familia
And through the family doctor and the family nurse program,
se mantiene un intercambio sistemático con estas personas,
we hold systematic, regular exchange with these people.
que está atento no solo a su estado de salud,
The doctors and nurses are aware and follow up not only the health conditions of these people,
sino a las condiciones sociales que rodean cada uno de los casos.
but also the social conditions that prevailed in the setting where these mothers and children live. Okay, that is my answer. Do you have any doubt?
Doubt.
Just one last question. Before we close and wrap up and move on to the last presentation, it's regarding community engagement strategies. So one of your main strategies was to use volunteers for community education and follow-up. Were there any other strategies you used, community-based support or community engagement strategies that were used in addition to using a large number of volunteers?
A ver, dentro de la estrategia educativa del programa,
The educational strategy under the program
está enfatizada en diferentes líneas de trabajo.
focuses on several work lines.
No solo tenemos a la sociedad civil o personas con VIH incluidas,
We do not only include civil society organizations or HIV positive people.
tenemos adolescentes incluidos como línea estratégica de trabajo,
We also work strategically with adolescents or teenagers,
a las mujeres,
women,
personas que practican sexo transaccional, que hoy estamos organizando un poquito más,
people practicing transactional sex. In fact, we are currently working much harder with them.
hombres que tienen sexo con hombres.
As men having sex with men.
Cada una de estas líneas tienen representantes que trabajan en la comunidad,
Each of these groups have representatives working in communities,
incluyendo instituciones laborales
workplaces,
y otros centros culturales que también pueden apoyar el trabajo y la incorporación de personas.
and also at cultural institutions that could help us add new people, new volunteers to the program. Are you pleased with the answer?
Yes, thank you very much.
Thank you.
There is one more question for Cuba. So it seems like the final status for HIV, the final HIV status for children is determined at 4 weeks or 4 to 6 weeks. So are there no women who breastfeed in Cuba? There is no breastfeeding. It's a no breastfeeding policy.
A ver, nosotros seguimos sin aconsejar la lactancia materna
We continue to discourage breastfeeding
en aquellas personas que paren sabiendo que son positivas y aquellas personas
for those women who give birth and women who are HIV positive.
y las que se incorporan infectadas en el embarazo. No damos lactancia materna, no la aconsejamos y
In
hasta ahora
fact, we do not advise, we do not recommend that these women actually use breastfeeding.
es lo que tiene recomendado nuestro protocolo de...
That is according to the recommendations of our Cuban protocol.
Very clear.
Thank you. So without any further ado, we'll move on to our last presentation, which is a joint presentation by Daniel Lobier, who is the Director of Strategic Information and Planning for the HIV Department in WHO, and to James Chiari, who is the coordinator for the Human Reproduction Team of the Department of Reproductive Health and Research at the WHO in Geneva. So we will turn it over to them to close and indicate what the next steps and future directions are with regards to validation. And we encourage you to keep sending in your questions, and we will continue to answer them online as much as we can. Over to you, Daniel and James.
So thank you. I mean, I think the focus today is really on Cuba and all the partners that have made it possible. The people on the WebEx, I think it's got great attention. It's got attention globally as the beginning of the elimination of mother-to-child transmission and we'll hear about HIV, we'll also hear about syphilis. We did just want to put up a few of the next directions because we've also started the global validation process. We've established a committee and just wanted to brief you on some of the next directions. So really working, and these come from some of the comments from UNAIDS, that this really is, Cuba is a great moment, but it is the beginning, and the beginning of, the very early beginning of the end of AIDS. It's one of the first times where it has actually been validated the impact in a clear way, in a way that's been prominent, that has involved all levels, countries, partners, and globally. So first, really, we think it is to celebrate, consolidate this agenda, which has started, which is now established as partners. Two levels. First of all, maintaining this partner movement, HIV, reproductive health, maternal and child health. It certainly goes beyond these issues. It works very well in the Sustainable Development Agenda. It cuts really into health, into supporting countries. But then secondly is to deepen and widen this. So Cuba really as a first step to bring in 1, 2, 3 countries per region in the next year with some funding. So actually for showing, validating impact, this is relatively modest support that is needed for something that gets this amount of prominence. But there is a challenge to extend this to Africa. So that's the first bit really where we're pausing to celebrate today, to consolidate this agenda. But in the Global Validation Committee, clearly 2 other questions came up. First of all, the huge effort that's gone into Cuba. Can we scale this to 10, 20, 40 countries? And to an extent streamline the process, country, regional, global process. So we're going to be working on being very clear on global and regional roles to try and make sure that there is probably one validation step, that those roles don't overlap, and a differentiated approach to countries, to the intensity in which we engage in countries. Some countries we've got great preparation for. There's a lot of the data, a lot has been confirmed through other reviews, other analysis, program reviews in countries to ensure we get those key components done. So that's the second direction. And then the third question is we want to extend this agenda to better include, which Deborah mentioned, the great progress in Africa where hundreds of thousands of infections are being eliminated on a yearly basis, and link this strongly to the global plan. So we're working on including a pre-validation stage that can recognize that, that can recognize the significant reductions in the mother-to-child transmission rate 4 or 5 times to below 5%, and bring in a progress plan in those countries so it can go to the next stage. So work a lot on that preparation phase, that pre-validation, and then also in the countries that are validated, in sustaining validation, that we can sustain it and show that this can be used, this validation process, not just to prove, but to look where we can improve the program with many of the recommendations which have come up from the country and from partners. So very briefly, the Global Validation Committee met, and there's really 6 areas that are draft work priorities for it going forward. The first 2 are really to continue to validate countries and or regional reports, and to provide template to standardize this process, and to consolidate the tools. As Chika was saying, we'll make them available, we'll look to simplify them. We'll look to try and link them to some other processes that are going on in country, program reviews, M&E assessments, human rights assessments that are available, so that they build on work that is done. The second set of actions, 3 and 4, is to strengthen some of the stages. So we're going to work, I think, as a priority on the pre-elimination impact stage, which is trying to bring in those countries which have not quite got their caseloads down, but which there is being major progress, where we can prepare them over the next 5 years for the next stage, and to pilot this in an African country, and to firm up the sustaining stage. And then the last 2 is to really firm up to work on the pipeline of countries with the regions, with the partners we've got today, and we've got in the WebEx, so that we have a clear pipeline of countries from each of the regions, so that they can draw in and strengthen this agenda, and do some of the readiness analysis, so we have some of the analysis up front of where countries are progressing. And then finally, to support that, and this is where we really are reaching out to partners, is a resourcing plan for this. The validation is still relatively light to show clear evidence of impact, to show the type of exposure that we've managed to get around this agenda with the good work of Cuba, support of PAHO, support of the Global Validation Committee. But it will require some resourcing if we are to extend this to those 10, 20, 30 countries. So those really are the actions, the direction we're coming. We just want to stress that to celebrate this, Cuba in its own right, what we've learned from it, the incredible process that's been done in countries. But it is the beginning, the very early beginning we see of the end of AIDS. We want to maintain the validation structure, which has now been established at the same time. The Global Committee make sure there's regular calls, there's at least a yearly meeting on this, which can validate countries as they come up. Firm up the pre-elimination phase, and then simplify some of the tools and focus it on countries. And then our real priority is to focus this agenda as much as we can on country validation, to bring in the countries from each region so we have validation. The slide seems to have changed, and to get partners around to support countries, to raise some funds to support the countries so we can have at least one from each region in the next year being validated as part of this agenda. So those are really some of the next directions we'll be working on very strongly. We really just want to finish by thanking all the partners who are there, the countries, to really celebrate Cuba. But we will be taking this agenda further to start to consolidate this first evidence of increasing number of countries which can validate the end of the important transmission of HIV and syphilis in countries. So thank you all very much. I'll pass on to James to make some additional comments because this is dual elimination. It's got an important reproductive health agenda and maternal and child health agenda.
Thank you very much, Daniel. And thank you everyone for joining the call. I would just like to echo Daniel's statement that this is really Cuba's day, and congratulate Cuba for having achieved this validation of elimination. I think Daniel has taken us through the next step, so I will not repeat that, and to just say that since the interest that has been shown, it really shows that this is really just the beginning. And I think we have an opportunity to really make a lot of impact, both in terms of preventing congenital HIV and also congenital syphilis. I just wanted to highlight something on specifically for syphilis because it's kind of a bit of a different disease, and we have a lot of in common with HIV, and I think it is really an opportune time to link up the elimination of these two diseases in terms of elimination of mother-to-child transmission. However, I think the key for the countries as we look at eliminating congenital syphilis will be treatment, the detection and treatment rates that are required. Because one thing is that syphilis is a disease that has high transmission in terms of the number of births that will be affected. If there's no treatment, can be up to 52%. But however, if treatment is given before 4 weeks, that is at least 4 weeks before delivery, then it's 100% effective. And therefore, as you can see in that slide, even with very low prevalence, we need very high rates of detection and treatment to really achieve the case rate that is required for elimination. And with the prevalence rates that are above 2%, as you can see, that is when we really need to look at dealing also with the transmission with the prevalence among mothers. So we need, for the low prevalence countries, then the key is really to achieve high rates of detection and treatment. For higher prevalence countries, then something will have to be done to achieve the targets for elimination to actually reduce the prevalence among mothers. But again, just to echo what everyone has said, thank you very much, and we look forward to continued working together. Thank you.
Thank you very much, Daniel and James. And we'd like to wrap up this webinar by again offering our congratulations to the team in Cuba and to say that we are very delighted that you were able to join us today to give us a peek into how you were able to achieve dual elimination. And a big thank you to all of our presenters, to Chika Hayashi from WHO, to Deborah Van Zinkernagel, to Sonia Coffey, to Dr. Field, Dr. Rodriguez of Cuba, to Alina Perez for helping to organize this, Priscilla Adele of UNICEF, and again, Daniel Obier and James Carey. Thank you everyone for giving us a very comprehensive overview of the validation process and criteria. We encourage all of you who joined us today to keep on sending in your questions. We'll do our best to send them to the team in Cuba and to answer them for you, in particularly as we move towards looking at how other countries can also, that are close to achieving elimination, dual elimination, can be part of the validation process. So thank you again, and we look forward to hearing from you and seeing you on our next webinar, which will be at the end of this month, and we'll send out an announcement about that shortly.
But it was also last minute process. It's not like we weren't doing it. Actually, it was Carisa's idea.
Thank you.
Bueno, muchas gracias a ustedes por las felicitaciones y por darnos esta oportunidad.
Thank you for your congratulations and thank you for the opportunity to be with you.
Thank you.
Gracias.
Bye for now.
Gracias, chao.